Hello, everyone. I'm Alicia Swami. I'm here with Keely Severson, Eric Johnson, and we are exposing mold. Today, we have Dr. Paul Harch. Thank you so much for joining us today, Dr. Paul.
My pleasure. It's great to be here.
Absolutely. Now, from what I know of you, you are a world-renowned expert in hyperbaric medicine, diving, and you are an emergency medicine physician. You've used hyperbaric oxygen therapy to treat more than 100 different conditions, including stroke, dementia, autism, and traumatic brain injury. Currently, you serve as the clinical professor at LSU School of Medicine in New Orleans. And you also published a book, The Oxygen Revolution, which explains HBOT, hyperbaric oxygen therapy, as an epigenetic therapy that has revolutionary effects on medicine and neurology. Wow. Thank you again for joining us. Please tell us more about your specialty.
Well, and before I do that, I'm going to add one other thing. Inadvertently have treated patients with mold problems, central nervous system problems related to mold exposure, which I guess is how I ended up here today. And that kind of came out in our discussion. But yes, this is gosh, how can I explain it? Probably the most misunderstood, misperceived, and unappreciated therapy for the last 362 years in the field of medicine. I mean, since 1662, it hasn't really been understood as to what this can do. And it wasn't until the last 10 years that, while we realized it's traditionally been applied to wounding conditions anywhere in the body and of any duration, we now know that probably the primary method of action and improvement on patients is by treating the underlying disease processes that cause diseases, and by doing that through affecting gene expression. So this therapy has now been shown to turn on or turn off over 40% or 8,101 of the 19,000 protein coding genes in our DNA. And by doing that, it is able to treat disease. So that's where we are today with this therapy, a whole new understanding of it.
Thank you so much for that. Have you ever used it to treat chronic fatigue patients, people with chronic fatigue syndrome as a diagnosed issue?
Yes, and this happened early on. And this was before chronic fatigue was more well defined as a disease entity with certain criteria and so on. We would see, or I would get referred patients with chronic fatigue from, let's say, a known cause like carbon monoxide poisoning, or various other neurological problems, identified or not, where people were having, unexplained fatigue. And a number of these I treated in the early 90s, and we saw substantial improvement in them. And we now understand how this might be occurring. Hyperbaric oxygen, among the other places where it has activity, our mitochondria are sensitive to it. And of course, the mitochondria is the little energy factory in every cell, burning glucose, protein, carbohydrate, and giving us all of our energy. And we now know that hyperbaric oxygen directly impacts the mitochondria. In fact, even proliferation of mitochondria, expression of mitochondrial DNA, the genes in the DNA, and so on. So yes, early on in this, I found that patients with chronic fatigue could respond to this, but I didn't really seek them because I was uncomfortable not knowing what I was treating. And I couldn't really say to someone, oh, yes, this was a good treatment for chronic fatigue. It may be, and now we just have a better way of evaluating someone for the potential to respond to hyperbaric oxygen.
Well, let me throw in a curious thing about the chronic fatigue syndrome terminology. The Center for Disease Control, Dr. Gary Holmes, was so baffled by what he was seeing that they didn't really do a clinical definition. They simply threw together an outline that he said in his preamble is a starting point for further research. He was looking at some clusters of sick people, sick teachers in sick buildings, and couldn't figure out what was causing it. And without a clue to start with, and so many symptoms that were all over the map, they just kind of made this research instrument to get their foot in the door and get the study going. And instead of doing this, doctors started throwing the name at everybody and didn't really follow through to find out, wow, what's in the sick buildings? What's causing this? So the
When
chronic
was
fatigue
that?
syndrome, pardon?
When was that?
1988.
Okay,
The original name for this entity of reactivated Epstein-Barr virus was chronic Epstein-Barr virus syndrome.
right.
A very good name, medically impressive, and it makes sense because you can test for it. But when they found out that other viruses were being reactivated, they couldn't really keep EBV in the name. So they sort of backed off a little bit and said, we need to reevaluate, start over. And somehow that didn't quite happen. Instead, the name created more confusion than it solved. But nobody really liked that chronic fatigue or chronic fatigue syndrome name because it had no impact on doctors. And somehow things managed to stay that way for the last 36 years. But I'm really curious as to your reference to this being hyperbaric oxygen being studied back in the 1600s and being overlooked for all these years. How could that possibly happen?
Because no one could explain how it was working. So it was first started with pressurized air. And by the late 1800s, there were multiple centers throughout Europe. All the large European cities had multi-place chambers, meaning chambers large enough to walk into, sit down, accommodate multiple patients. And they were treating people for a variety of conditions. But scientifically, it couldn't be understood. It couldn't be explained. Oxygen wasn't characterized or discovered until Priestley, what was it, I think 1861 or so. And so exactly how this pressurized air was working was not very clear. Now we know that it's the combination of the pressure of the breathing gases as you increase the pressure in the chamber and barometric pressure itself. So barometric pressure, our atmospheric pressure that we're all existing under, when you change that, almost all living organisms are sensitive to that. I'm talking the entire phylogenetic spectrum. And that has never been appreciated. Rheumatoid arthritis patients knew it, and osteoarthritis patients know it. When a new front comes in 100 miles away and the pressure starts dropping, they feel it in their joints. We are pressure sensitive, but nobody understood that that pressure was a separate entity from the pressure of the gases that you were using. And in the absence of that, and the ability to defend what was going on, people made claims. Yes, we treated someone for chronic syphilis, or I grew hair, I was bald, etc. The medical profession was embarrassed by it. And eventually it somewhat died out and it got resurrected and was then recharacterized as hyperbaric oxygen therapy with the use of 100% oxygen. And still to right now, really the last 10 years, that confusion has persisted until it's now being appreciated that barometric pressure and lesser amounts of oxygen than 100% are in fact very bioactive. Now we've got a whole new understanding of it, but it's based on the science, which was not understood.
Well, you said in your talk that this was used years ago to treat survivors of the Spanish flu.
Yes. And, everybody forgot it. So the introduction of hyperbaric medicine After it died out in the late 1800s in Europe, in 1918, right in the midst of the Spanish flu, Dr. Orville Cunningham in Kansas City was noting the increased mortality of Spanish flu patients at altitude in the Rockies while he was vacationing there. And he thought, lower pressure, lower oxygen, higher mortality. What would happen if we increase the pressure and increase the oxygen? Went back to sea level in Kansas City, built a chamber, and the day they were to be functional and operational with animal experiments to begin, he was brought a dying Spanish flu patient. And this is described in a book and in a medical journal article, how with just pressurized air at a modest pressure, these patients pinked up, their agonal breathing improved, and with one treatment a day for 4 to 5 days, they got them over that critical period where today we put them on a ventilator, the COVID patients, and they go on to die. They avoided any type of mechanical ventilation. I don't even think it was available in 1918, but they survived. And pretty soon he was flooded with Spanish flu patients. And they built a 108-foot chamber and then a 5-story steel ball hyperbaric hospital and so on. Well, in the modern era, once World War II came and that chamber got recycled for scrap and so on, everybody forgot this. And it got reintroduced in the United States by the US Navy for treatment of diving accidents, and in the Netherlands for oxygen deficient syndromes, and it was on pure oxygen. So once again, it's a curious historical phenomenon that everybody just ignores the past history in medicine, and you go about with your new invention. Yeah, 100% oxygen.
That is absolutely phenomenal. It seems inconceivable that this could have fallen by the wayside.
It is.
Tell us your story, how they discovered that it wasn't really the oxygen, that it was just the air pressure.
They didn't discover that. I mean, it was, it was pressurized air, and it was a hyperbaric treatment. And it just was serendipity. He decided to put these Spanish flu patients in the chamber. In the more modern era, though, this has come to the forefront when an error and mistake was made in doing a cerebral palsy study up in Montreal. And I had treated the first cerebral palsy children here in North America, in New Orleans, beginning in 1992. And as we reported this, and the experience was attempted by other doctors, eventually a series of experiments were done up, clinical trials, I should say, were done up in Canada. And when they designed the experiment, those of us who had input and access to the doctors there, we couldn't get them to use the identical protocol that we had shown work down here, meaning the identical dose. Instead, an outside consultant who knew really nothing about hyperbaric medicine was brought in by the Canadian government to be in charge of the trial. And he thought that giving a control group pressurized air was a placebo. And lo and behold, it wasn't. It had the same effect it did for Cunningham's Spanish flu patients. It was bioactive, and these children improved. And it just threw the whole, field into confusion, because it was based on the definition of use of 100% oxygen, and it had to be a placebo effect in this control group. Well, the US military made the same mistake after we introduced the use of this for treatment of veterans with blast-induced traumatic brain injury. And they constructed a series of trials with the same control groups in it with pressurized air, and lo and behold, it worked in a number of them. So what's happened now is it brought out this phenomenon, and in the process, right in the midst of it in 2006, I went to the Food and Drug Administration to get an investigational new drug exemption for the trial we were doing on traumatic brain injury. And for the first time at the FDA, they had moved hyperbaric oxygen from the devices side over to the drug side, as oxygen is a medical gas prescription drug. And when they looked at my application, they said, "Doctor, I'm sorry, we can't approve your protocol and proposal because this is the first time we're looking at hyperbaric medicine, and we view your drug as a two-component therapy, barometric pressure and increased oxygen." And I said, "Wow, you guys are crazy. This is the first time in my career anybody mentioned anything about barometric pressure." So I went to the library, and what did I find? 50 years of elegant physiology showing that pressure is bioactive. And now it's put the whole field in a different light. And we're in the process of publishing more and more material about that. So that's where we are now in this field, is the appreciation that a whole range of pressures and oxygen levels can be bioactive for you, your problem, and even mold.
Doesn't the result clearly show up on oxygenation of the blood?
It does, but barometric pressure doesn't show that. Increased pressure of oxygen does. And increased pressure of the air. So when you compress somebody on air, all of the gases you're breathing are oxygen, nitrogen, argon, trace other quote inert gases. All of them have an increased pressure, and that is bioactive. But in addition, the change in barometric pressure itself has a bioactivity to it. And that's the new appreciation.
I remember the Navy was interested in this because the nitrogen narcosis, the bends, where if a diver comes up too fast, they get bubbles in the blood and have to be put in a pressure chamber to keep from dying, basically.
Right. Well, that's how hyperbaric oxygen really made a comeback in the United States. It was through two routes. The one in the Netherlands I was talking about in the 50s, late 50s, and the US Navy. So normally, nitrogen narcosis is that narcosis or, psychosis, if you will, that occurs the deeper you go due to the pressure of nitrogen, that gas. Decompression sickness is once you've absorbed all that gas, you're now coming up too fast. Like you say, you form bubbles and the gas separates. Well, what the Navy did when oxygen finally became available in bulk amounts was they started using it. Normally, you just recompress. Someone comes out of the water, decompression sickness, you put them in a chamber immediately and you recompress them to the depth of their dive and then some on air. And of course, the oxygen goes up in that, but not like using pure oxygen. So when they found out that maybe oxygen could help get rid of that nitrogen quicker, they started adding oxygen into those compression tables, and they used pure oxygen. And that's where the application came from with the Navy. And then clinically in the Netherlands, they were using it for like the flesh-eating bacteria, carbon monoxide poisoning, things where there was very little oxygen. You wanted to give as much as possible. So the two of them found out how much oxygen you can safely give. It was used with 100% O2, and the medical profession redefined hyperbaric therapy as hyperbaric oxygen with 100% O2. And that's where we are clinically today.
I remember the work of Dr. Paul Cheney. He became concerned about a condition called the patent foramen ovula, the hole in the heart.
Yes.
Where this is a problem that really afflicts divers, because with that hole in the heart, it'll blow wide open. Contaminated blood will go directly into the brain, and it's super dangerous for them. So divers have to be worked up to find out if they have this condition, because essentially they can't go below like 30 feet.
Well, it turns out nobody does get worked up for that. And roughly 30% of adults, all adults, 30% of them have that patent foramen ovale, that opening that forms in utero that doesn't close in 30% of people. So when you dive, that inert gas you take up, the nitrogen, is in your tissues. As you come up, you release it. And a certain amount is released into the bloodstream in the venous side, comes back to the heart. If you've got a PFO, yes, you're more at risk for that going through to the other side and now going to the brain and the rest of the body. Otherwise, most of it gets filtered by the lungs, but even some can sneak through there. Surprisingly, though, people do not get screened for PFO before diving.
Wow. Dr. Cheney had a chronic fatigue syndrome patient that had this condition and had surgery for it to close the hole in the heart.
Yes.
And it worked for a short period of time until the hole blew open again.
Well, they have good closure devices now. They usually don't blow open. It's a little umbrella that goes through the hole, expands, and then compresses. So it ends up really occluding the hole, unless you've got a huge hole and then you need actually cardiac surgery to close it.
One of Dr. Cheney's findings was increased pressure outside the left ventricle. It would cause a backflow in the heart. So it's always been a question as to whether or not the impairment of the circulation, some problem with the cardiological system, was putting an enlarged heart condition at the center of this controversy. And maybe this was actually blowing open that hole in people who otherwise would have had it closed.
Well, actually, that can happen in anybody normally, and all you need to do is hold your breath. So if you're someone who has a patent foramen ovale, that patent means that normally that hole closes. There's a flap of heart tissue that sits over it. The people who have an opening there, these are the 30% figure comes from autopsy studies where they do an autopsy on person and they're able to put a probe through that. Well, if you, for instance, hold your breath right now, strain, and do a Valsalva maneuver, which is straining with your breath hold, what happens is pressure goes up in your chest. Blood return decreases to the right side of the heart. When you now release and take a breath, pressure goes down in the chest and all the blood rushes into the chest, the right heart. And that big bolus of blood raises the pressure in the right atrium and it flaps open that patent foramen so that the flap is on the ventricle side or on the left side of the heart. So what happens is the bolus of blood comes in the heart and it opens it up. And now if you got bubbles in there, they go through to the left side of the heart and from there, left ventricle to the brain. So anybody can do that. It's just, you don't want to be doing that when you come up from diving, on the way up.
Wow, I remember Dr. Cheney used to use a breath hold test as part of his diagnostic procedure.
Yes.
But I didn't, yeah, amazing.
In fact, it's done in what's called a transesophageal echocardiogram. So, you've probably heard of echocardiograms where you take an ultrasound and put some jelly on your chest on the left side and you slide it around and you're able to look at the heart's function. Well, you can get an even better picture if you swallow one of the endoscopy tubes. They sedate people, you swallow it. It's got a camera, ultrasound camera and emitter on the bottom of it. You put it right behind the heart and you can get beautiful pictures of the heart. Well, what is also a part of that is they do a bubble contrast, or you can do it. It's optional if you're looking for a patent foramen. And what they do is take a little saline with some air in it, shake it up, tap it, get all the big bubbles out, but microscopic bubbles are in there, and they inject it. And they watch it go to your right heart and then have you hold your breath. And on release, if you've got a PFO of significance and it opens up, you'll see those bubbles go through to the left side. I wouldn't want it done, but I'm telling you, it's a routine test that is done. It's just got a little risk to it.
Wow, the very first doctor that I ever heard describe extreme mold reactivity and advised his patients to move out of their house and take nothing, not even a toothbrush, was a diver. He was a sport diver. And he was forced into retirement because he got the bends when he was only 30 feet down, came up too fast, and this left him impaired for, as far as I know, he never recovered. And he had this condition. So I've always wondered if the mold reactivity and the combination of the patent foramen ovale was playing into why he became disabled.
It may have been. There's another component of that. He may have had an air embolism, a significant air embolism. So the people who are shallow diving, if you will, 33 feet or less, you have to be down underwater for a long time to take up enough nitrogen and then come up quickly to get decompression sickness. Often what happens in shallow water like that is people on the way up are holding their breath. Let's say they run out of air, they have an equipment malfunction, or they panic, see a shark, do whatever, and bolt to the surface. What ends up happening is if you are not breathing just right to make sure that you don't, first of all, if you hold your breath at 33 feet and go to the surface, the air in your lungs doubles in size. Your lung volume expands to double if nothing was done. Well, you have a rib cage that prevents that from happening. So what happens is the pressure goes so high in the lungs that now the air ruptures into the blood vessels and you send a stream of gas directly to the left side of the heart and from there to the brain. And that is the instance of air embolism that usually causes severe damage, where people have, brain involvement, total involvement, are then disabled and so on. You can also get it in the spinal cord, but mechanism's a little bit different. So I don't know, without the details of it, we don't know what happened to him, but he did something wrong there and ended up with significant bubble-related injury.
Well, it always seemed that mold illness, biotoxin illness, was primarily a problem of oxygen uptake. And I remember a lot of people went for oxygen HBOT and tried it out. And they said it felt great when they were there, but then they'd always relapse. And they weren't really combining this with mold avoidance.
It may also be a dosing issue too, or they didn't do enough. To get permanent changes in a chronic condition, a chronic wounding condition or inflammatory condition, you generally, in other words, chronic, you're 6 months out, let's say, or more, you need to do about 40 treatments. Well, if people don't see symptom change early, lots of times they'll get discouraged and they just stop the treatment. And it's, oh, I did that, it didn't work. The other thing is that the dose can be wrong, or like you said, if you don't get rid of the continuing exposure, you can maybe help repair damage, but if you're continually stimulating your immune system, you're not going to see a significant symptomatic change in people.
When this therapy is done.
Let me just say one other thing. I'm sorry, Eric. That goes directly to what I mentioned at the very start, inadvertent treatment of mold patients. 2 of my, quote, Alzheimer's patients that I treated, one is the published case, the other one not. Both of these people improved. Both of them had, well, at least one had continuing mold exposure. The other one, the published case, had been in a mold environment, finally had to quit work and was now disabled out of that environment for about a year. Now, we don't know about her home and involvement there, but she at least still had the toxin in her, had done no mold exposure. Well, it wasn't until after I treated them with hyperbaric oxygen, both of them improved. Both of them went on to then get some mold detoxification. And the one, the published case where we published the PET brain imaging before she got the mold detoxification, she may have had some transient improvement there. The other one clearly did. In fact, I just saw him last week. He's now, 8 years out from when I treated him.
Wow, what really got me into mold was my own personal exposure as a child. But being hypersensitive, I was able to watch the results of people with chronic fatigue syndrome who were getting antiviral therapy. And it seemed to help. They'd knock down the EBV, or in certain cases, if they had a HHV6 and got treatment for that, they would improve a little bit. And then I'd watch them, and if they'd go into a moldy building or move into a moldy house, they'd relapse and completely lose their gains.
Right. Well,
So
you have to eliminate the exposure, and especially when the immune system becomes involved. As long as you got the exposure, you're continuing to stimulate the immune system and its inflammatory reaction. So it is a multi-component approach. You've got to treat existing damage or try to remove the source and the repeat stimulation, and also try to calm down the immune system.
I'm amazed that this therapy has been overlooked since the 1600s. That's
So
mind-boggling.
I was blown away when I finally found this out. It's not really taught when you get into hyperbaric medicine. I mean, there's some stuff. Oh yeah, back in 1662, Henshaw used a chamber to compress people on air. But the whole modern era use since 1960 in the United States is dominated by the mentality in this one medical society that teaches that hyperbaric oxygen is the use of pure oxygen it used to be, they set a limit, 1.4 atmospheres or greater. Anything else less than 1.4 atmospheres or greater pressures with less than 100% oxygen is not hyperbaric therapy or hyperbaric oxygen therapy. It's not, it's completely undefined. They don't know what it is. It's make-believe, it's just totally muddled thinking. But that's been the state of things. And because of this dominant mentality, that's what has driven the whole hyperbaric medicine field, the government's appreciation, the military's appreciation, reimbursement sources appreciation, and so on. And it's unscientific and totally misguided. And we're in the midst of trying to correct it right now.
Well, I love old medical books, and it's amazing to see how wise, how much education, how much knowledge has been known for so many hundreds of years and then seemingly lost when people say, oh, well, this was never known before, when it was. And one thing I'm very curious about is that blood oxygenation has been a topic since the 1600s. And the oldest blood test is the erythrocyte sedimentation rate, the Westergren tube, where fresh blood is put in a graded tube to see how quickly the red cells settle out of the plasma, and the rate at which it settles, that clear plasma up at the top, gives you your sed rate. And this is the first blood test. It's been going on for a long, long time. And it would be the logical thing to look for when you're wanting to check the condition of the blood for oxygenation. Is there any record of people having done so?
Well, yeah, let's go back. Oxygen really wasn't appreciated and its effects, oxygenation, the blood, etc., until Priestley really identified it and isolated it. But the sed rate doesn't measure oxygenation per se. What it's measuring is fibrinogen, which is one of our blood proteins involved in clotting. But it's also a blood protein that's an indirect measurement of inflammation. Now, the immune system is so complicated. And of those 19,000 protein coding genes, we have a huge number of them that are involved with the inflammatory process and our immune system. And so there are many different ways that inflammation, or I should say that many of these different proteins, they get activated during inflammation. Fibrinogen is just one of them, and it's kind of a crude test. So usually to have an elevated sed rate, you've got to have significant inflammation that at least will trigger increased fibrinogen. So with that increased amount of fibrinogen in the blood, you can think of it as kind of thickening the blood such that red blood cells, it's harder for them to settle out by gravity, which is what that sed rate is measuring. But there are many other ways to look at it. It doesn't really tell us about oxygenation. It just tells us you've got systemic inflammation.
One of Dr. Paul Cheney's observations was of an artificially low sed rate. Inflammation, it should be higher. And
yes.
He actually saw a 0 sed rate in his patients. And when he moved to North Carolina, he began checking sed rate And every time he saw a 0 SED rate, he'd work up for his other chronic fatigue syndrome parameters. And sure enough, they were consistent.
I got to tell you, I have never heard of a 0 SED rate. I don't know how that could happen. That implies that the red blood cells settled down and separated in 0 time. I'd have to, you'd have to send me to what he did, and I'd have to see about that. Or see what they did. That's a new, I've never heard of that. A SED rate is 0. The normal,
the major controversy over what's called MECFS, myalgic encephalomyelitis chronic fatigue syndrome,
right,
is of 2 parallel disease entities. The myalgic encephalomyelitis is the name used in United Kingdom and Canada, and chronic fatigue syndrome for what appears to be very much the same thing. And in both entities, a strangely low, even 0 SED rate was the major finding. And it turns out that a 0 SED rate is known in only 5 diseases: polycythemia, hypogammaglobuline, a few others that I can't pronounce. Sickle cell anemia is one, apparently, has a strangely low SED rate. So it seemed to me that if SED rate is a test that's been used to be routine, that was on the standard blood panel, and lately it's so crude that they've kind of dropped it, but there should be a long history of people's SED rates that we can go back and see if this has increased in society.
Well, yeah, but it also implies the flip side of that. If we say that fibrinogen is an immune protein, that with mold infection and these others, that there is some immune dysregulation. If in fact the SED rate is 0, and that's not a normal condition or a situation, which goes to, I think what is partly going on in this syndrome is that there is, with mold, there's immune dysregulation.
Completely. And Dr. Cheney said that if you want to make the case for inflammation as the cause of chronic fatigue syndrome, it seems kind of crazy because here you've got the exact opposite indication with a low SED rate.
Mm-hmm. Well, I'm going to back up here and just say, with hyperbaric oxygen, it has been used and been successful with, and the protein expression that has been shown with human cells in a single hyperbaric treatment. The largest clusters of genes that are turned on are the anti-inflammatory genes and the growth and repair hormone genes. The largest clusters suppressed, and this is in normal people, normal human endothelial cells, largest clusters suppressed are the pro-inflammatory genes and the genes that are associated with cell death. And the net effect of that is that it is inhibitory of inflammatory conditions, but it is also a treatment for people with a dysregulated immune system. So as part of their pathology, you may have, let's say, suppression of immune function. This can potentially stimulate your immune function in a beneficial way.
Well, I can't help but wonder if there's a separate mechanism rather than fibrinogen, rather than the clotting, if somehow this disease is affecting the red cells and platelets in an undiscovered way that's accounting for this bizarre effect.
Oh, I wouldn't be surprised. I wouldn't be surprised if it's primarily affecting the immune system. You know, well, you could just go to what is the medical group of patients that are most susceptible to fungal infections? And I'm not talking the toxins, but just to fungal infections. It is immunosuppressed patients. It is those with a poorly functioning immune system, diabetes, people with cancers of all types, people with other immune system dysregulatory syndrome, autoimmune syndromes. Those are the people who get fungal infections. and people who have been on antibiotics where you've killed off their normal bacteria. So, I mean, it implies that with fungal infections, the immune system is affected, first for the infection itself and your susceptibility to it. But, once you've got it, there's probably affecting your immune system and your reaction to it.
The position of the Center for Disease Control on toxic mold has been that this only affects people who have a compromised immune system. In fact, that's what Dr. Gary Holmes was saying when he came to investigate the sick buildings, is that these teachers should not have problems controlling Epstein-Barr virus. This should only happen in people who have cancer, diabetes, AIDS, or some classically known immunosuppressive condition, but they did not. The only thing that they had was exposure to this black mold. So that was where the speculation began, that perhaps this toxic black mold did possess immunosuppressive qualities that was being overlooked.
Sure. And it may be the toxin in the mold that's responsible. I mean, when people actually get a mold infestation, they're generally pretty sick, an active mold infection. That's what we see in the hospitals. And so this is something that, goes to my ignorance about the whole field and mold infection and the chronic fatigue syndrome, is this actually some degree of low grade infection, but it's the toxin that's causing so much of the dysfunction? I don't know. But interestingly, when it seems that when people go on anti-mold, antimicrobial therapies, that they do get some improvement, which would then imply that they've got an active infection going on. So
far, the MECFS researchers have failed to find any common denominator, any active infection that's broad scale common to the disease. But in people that have had this mold exposure, it's very common to see secondary fungal infections.
Well, I'm even talking that, like the black mold, for instance, or ones where you were just mentioning that they may have some low grade infection, but not the overt type that we see in people who are immunocompromised, like the ones in the hospital, the cancer patients and so on.
Can I ask you a question about that?
Yeah.
Are you saying when people are exposed to Stachybotrys, they have other low-grade infections that aren't healing?
No, I'm not saying that.
From the immune suppression? Oh, okay.
No, what I'm saying is that, the contention that those people in a mold-infested building, the only ones getting infected, have some type of immunosensitivity, that maybe it hasn't been identified. That's a possibility. But what I'm saying is that maybe these people, for one reason or another, and it may be their immune system function overall, they can get an infection with the mold, have the mold in them, but not get the overt severe illness like the people we see in the hospital with gross immune system suppression, like the cancer patients, the chemotherapy patients, autoimmune disease, where they have high fevers. You can culture the mold out of them. And that's aside from any effects of the toxin. I'm saying the people who are mold exposed and getting symptomatic from it may have some low-grade infection, because some of these people, or I don't know what percentage of them, seem to get better when you give them an anti-mold, direct anti-mold, antimicrobial, like fluconazole or something. And that's a part of it, in addition to whatever effects the toxin is having, which can stimulate their immune system or just cause toxicity, period.
We have anecdotal reports of Sporanox, itraconazole, being massively helpful for people in sick building syndrome.
There you go. I mean, you either have to be treating active mold in their body, or somehow that antimicrobial is affecting whatever toxin is given off by the mold or that they've ingested. Now, I don't know that it's been tested, or if anybody's looked at it, if it treats the toxin, but I mean, it's a possibility. It's more likely, what I'm saying is that they've got some low grade infestation of the mold that is not manifest by fevers and the severe symptoms, let's say, that the people in the hospital have, low blood pressure and sepsis and so on.
Makes sense.
I'm not
Good.
speaking from a standpoint of absolute knowledge of this, but I'm just trying to explain various phenomenon and what's been found and what to me makes some sense.
Absolutely. I had a question about traumatic brain injury, and this is something that we do see a lot in mold patients. Well, not a lot, because maybe not a lot of people are testing for it directly because there aren't a lot of specialists doing this, but people who have had mold injuries, they've done neuroquants. There's a doctor, Dr. David Ross out of Virginia, who has a program called NeuroGauge, and he's able to see the minute differences in the brain that maybe a regular technician wouldn't be able to do. Have you personally and in your group, have you been able to successfully treat traumatic brain injury from a mold exposure using HBOT therapy?
Well, hold on. Traumatic brain injury is usually the term that is defined by a mechanical force injury to the brain. So are you talking about patients with a mold exposure, infestation, toxin response, whatever, in addition to people who have had, or in addition to a traumatic brain injury that they've had from a direct mechanical force? Or are you talking about mold and its effects on the brain as a type of trauma? Which one are you?
I guess I'm asking the latter question, from a chemical injury to the brain.
Okay. All right. So that goes to the question I've asked, I treated patients with mold. And the answer is inadvertently, yes. That's what I'm talking about with these two patients that I treated. And we saw improvement. We saw the one case we treated, we showed the PET brain imaging. It's the largest improvement in brain metabolism that anybody has documented with PET metabolism brain imaging for any Alzheimer's patient in any study that's been done. We saw a huge increase. Was I treating mold? I don't know now. We didn't know what the cause was for her. We thought this may have had something to do with it. It was post-Hurricane Katrina, and she was working in I got to be careful how much detail I give, but a massive paper environment in a below sea level room in soggy New Orleans, where the place reeked of mold. No family history of it. And she ended up with, Alzheimer's, but dementia by age 48. So
Dr. Richie Shoemaker did a study on Hurricane Katrina, the St. Bernard Parish, and found that for a while there, the outside levels of toxic mold were so bad it would have qualified as a sick building syndrome.
no surprise. I mean, the city, with its humidity, the storms and so on, and the difficulty in detecting mold. I think I told you the story after the hurricane, and I mean, we went from one living situation to another, a FEMA trailer, all sorts of situations. Finally, we ended up looking for a home. For 2 years, we looked for a home, used home to buy, but to move. And I have a very sensitive nose for mold. We would walk into a house and I'd get 5 steps into it and I just say to the family, mold, we're out of here. And it took us 2 years to get a house that I didn't smell mold in. So, I mean, it's common down here and people don't appreciate it. And unless you got an external wall, or you've got a wall where you can see it, I mean, you can get leakage through a roof that comes into walls and it's hard to detect.
Well, I built myself a custom camper to recover from toxic mold exposure. So here I'm living in a RV park in Reno, high desert, And at one
Yes.
point, there were 5 people living in trailers in my RV park that were all Hurricane Katrina refugees come to Nevada to recover their health.
Well, this is what we thought was the problem with my wife, who was symptomatic after Hurricane Katrina. We couldn't figure out what was wrong with her. We thought it was all the mold because we were cleaning out, apartments, and oh my God, the mold exposure was intense. And it wasn't until she actually fell, hit her head, got an MRI, we found it wasn't mold. She had undiagnosed multiple sclerosis. Um, but yeah, the mold can be a big problem.
I understand there's a bit of difficulty in diagnosing true multiple sclerosis. They have to look for demyelination. And from what I've seen, people with mold exposure, particularly Stachybotrys, often wind up getting a pseudo MS diagnosis.
Well, I don't know. I mean, usually with MS, it is usually diagnosed, and what brings people to, a workup is MRI findings. So, I mean, they have symptoms, they get evaluated. MRI of the brain and spinal cord now are part of that evaluation. And I don't know what the percentage of MS patients who don't show T2 lesions on MRI, but it's a very high percentage of MS patients that will show that. Then often what is done is, to be certain, is they do a lumbar puncture and you look for myelin basic protein and other types of proteins in the cerebral spinal fluid, and then the diagnosis is made. So you're saying the Stachybotrys people, to have a pseudo MS diagnosis, meaning they end up getting characterized as MS and it not being MS, or it has an MS-like syndrome?
MS-like, I guess it's lacking in the anti-myelin basic protein, but it still has the T2 lesions and the elevated pressure on lumbar taps.
Well, that's not surprising. I mean, if you think of it, the T2 lesions that are seen in the white matter are non-specific. White matter is extremely sensitive to perturbations. So, for instance, traumatic brain injury, brain decompression sickness, carbon monoxide poisoning, MS, toxic brain injuries of all types, diabetes, hypertension, literally any insult to the brain can have manifestations or show injury in the white matter. So someone with a mold damage and central nervous system manifestations, it wouldn't surprise me if you saw T2 lesions on MRI, similar to what you see in MS or any other. I'm just saying it would make sense, and that is the very sensitive area of the brain. And the white matter is 63% fat. So the myelin that covers the axons, which is the white matter, the connecting tracts in the brain, is a fatty substance. And its ability to absorb toxins, it has lower blood flow, it has a lot of things that predispose it to essentially not tolerating any insult to the brain.
It was Dr. Cheney's MRI scans that actually scared the Center for Disease Control into convening the Holmes Committee to coin a new syndrome, because his brain scans were consistent with MS and AIDS patients. But we found that these lesions, these unified bright objects, they would move around, they didn't match MS precisely, and over time, sometimes they would completely disappear.
Well, interestingly, if they probably did brain blood flow scans, they would see and have a much higher percentage of abnormality than doing anatomic imaging, like with MRI. And that story's been told now with so many diagnoses, including the one where we made this discovery treating chronic brain injury, divers, brain decompression sickness. It'll show up on maybe 10% of MRIs, you might see a T2 lesion, a scattered 1 or 2. But on SPECT, they're all abnormal.
I've just seen a new paper out that they're moving away from relying on heart rate as a diagnostic or an indicator for symptomology in chronic fatigue syndrome, MECFS, and they're looking at brain blood flow. They're doing some kind of direct measure of the carotid artery to see how it changes over time to look for a correlation with symptomology.
Well, interesting. I mean, that's probably looking at carotid artery velocity of blood flow. But anything that disturbs the brain. So if you are symptomatic with brain symptoms, which can be, cranial nerve symptoms, problems with vision, speech, sensation, cognitive symptoms, etc., motor, sensory, coordination, all of the things that can identify as a problem in the brain. If you are symptomatic, you have to have a perturbation in function here. And function meaning disturbance in brain blood flow, metabolism, electrical, which is the final output of the flow metabolism, which means that you should be able to image it if it's sensitive enough on any of the functional imaging modalities. And this is what happened with us with brain decompression sickness, with carbon monoxide poisoning, with so many things. It will register that way and you'll see it. It's much more sensitive.
Well, there's some very exciting news, some information coming out of Australia. For many years, the similarities between MECFS, at least with the neurological presentation, mimicked MS so closely that it was assumed to be a demyelinating disorder, even without the anti-myelin basic protein. And Professor Leighton Barnden has used the world's most advanced MRI scanners, like 7 Tesla or something, that has shown up something that they didn't expect. There's actually areas of remyelination, extramyelination, exact opposite of what they anticipated.
Well, those are likely wounded areas that are self-healing.
Dr. Barnden says that he suspects this is a compensatory reaction to impaired neuronal energy, that the lack of conductivity was creating such problems for the brain that it was adding myelin to try to increase the flow of electrons.
Well, it's essentially a wounding, the condition is a wounding condition in the brain. And what you're seeing is areas of the brain that are spontaneously healing. That's a reactive change. React to what? React to the insult of the exposure. That was actually one of the original animal models that was used to study MS.
Well, I can't help but wonder if some of the people who are diagnosed with MS have especially if they have a history of mold exposure, really have this pseudo MS condition.
Possibly.
Hopefully, Dr. Barnden's research will be able to distinguish between the true MS as a pure demyelination problem and this other thing where we just have altered patterns of myelin in the brain.
Maybe, the problem with MS is that itself is not completely understood. It's thought to be an immune system disorder, but there's evidence that it may be more a wounding disorder, let's say from fat emboli, but something that is affecting the white matter there. If you look at the term multiple sclerosis, it means multiple scars. How do you get a scar? A scar is the end result of inflammation and the wounding process. So something is wounding the white matter in the brain in MS patients. And, the MS model it's felt to be some type of autoimmune phenomenon. That's not necessarily proven.
Yeah, it could be chemical injury.
Sure, it could.
And we really need to take a hard look at multiple chemical sensitivity and mycotoxins as being a class of chemicals that have the potential to create this condition.
Yes, I mean, there are a number of possibilities.
Because I do know people that the doctors kind of threw up their hands and said, well, we don't know what you've got, but it looks so much like MS that we're going to call it MS for now, or the pseudo MS condition. And they started conducting mold avoidance. They moved out of a moldy place, or they moved to a different, drier environment and improved. Whereas theoretically in pure MS, you wouldn't expect that.
No, it shouldn't.
I had
So
a
we
question.
might actually use that as a sort of a crude diagnostic. If somebody suspects they have MS, let's put them out in the desert and see what happens.
Sure. Well, the other thing that happens, though, you're also removing yourself from a lot of other potential exposures. You know, I mean, the desert is a pretty clean environment. Yes, there's some different pollens out there and such, but you know, overall, you're not exposed to all the chemical pollutants and barrage of it that you are in a city.
Well, my major thesis with mold exposure was that there always seemed to be a chemical that went along with it. That sometimes the chemical itself didn't create the problems, but if you put toxic mold and the chemical together, then it did. And that's what we see in sick building syndrome. We normally don't see Stachybotrys, which grows outside, causing problems in people, but put it inside a building with some chemicals, and then it does.
Well, you know, the immune system, there's that hapten mechanism of injury where chemicals attach to a substance and alter its immunogenicity, such that now your immune system reacts to it and even cross-reacts with your normal body tissue. So, you know, I mean, it's a possibility that, yes, a chemical in conjunction with mold, the combination of the two may be generating or maybe stimulant enough to your immune system to cause the disease itself.
That makes sense to me.
Sorry for being so annoying earlier, trying to ask questions.
Go for it.
I'm curious, are you having success using HBOT to treat long COVID by any chance?
Yes, I sure am. I've stopped counting. I've treated over 25 patients now with long COVID. We've only seen a non-response in maybe 2 of them. You know, I now tell people that that in fact we started on this based on how it works in acute COVID and how it works in Spanish flu, acute Spanish flu. The main effect of this, we believe, that the hyperbaric oxygen doesn't have much effect as an antiviral that is known. So that's not what we're treating. What we are treating and what determines the pathology in acute COVID, acute Spanish flu, and long COVID is your immune system's response. It's that inflammatory response, and the hyperbaric oxygen appears to inhibit that significantly. So if you look at the acute COVID now studies that have been published, and what happened with the Spanish flu reports, you know, based on that and what I told you about the gene profile expression for hyperbaric treatment in normal human cells, I started treating patients with long COVID because it's an inflammatory syndrome. And in fact, they respond. And I'm talking without any antiviral or any other agent, just purely the effect of pressure and increased pressure of oxygen. And it works.
Very cool. I'm glad that you guys are finding much success with that. Would you say, are there any instances where HBOT would be counterintuitive to use? Like, are there any known disease states that wouldn't do well utilizing this particular method?
Yes, the answer is that was my thinking back in 1989 when we started this. Once we had made the discovery with the boxers, the divers, and I started thinking, well, you know, this may be a generic treatment for chronic wounding in the brain. And what conditions do I not want to try this with? And the first one was multiple sclerosis because I didn't want all the controversy associated with it. I was just going to stay away from that temporarily. Well, I didn't stay away from the controversy, but that was the thinking. And the other was genetic syndromes. I could not see how we could change the genetic code such that we'd be able to treat a genetic syndrome. And that was based on my ignorance and our ignorance and understanding of our genes and how they work. I was taught that your genes are there when the baby's conceived and you make it to human, and every time the cell, reproduces itself or divides, or you make new cells, that's what it's there for, providing a new copy. Nobody understood that we had 19,000 protein coding genes and that every cell constantly is reading these genes in different combinations and sequences to make new proteins that run our cells and our life. That didn't come about until I was, way along in my career. And so when I started this in 1989, it was, we're not going to treat any genetic syndromes because I can just see that's going to be a failure. And then in 1995, after we had treated a variety of patients with different diagnoses, I got referred a young woman with a premature aging syndrome, a progeria syndrome, it's called. And the specific name of it is ceroid lipofuscinosis of the brain. I bet you never heard of that. But it is a premature aging syndrome and everyone dies by age 25. It's due to a gene defect with one of the fatty acids that's a intrinsic component of our cells, our brain cells, and of all cells, but in particular brain cells. And it eventually, the brain cells degenerate and die. And so we had no idea that this could affect it, but we were indexing the evaluation of every patient to brain blood flow imaging. Do a brain blood flow scan, next day in the chamber at a given dose, take them out, repeat the scan. And we were looking to see if there was a change on that second scan, could it predict who would improve with repetitive treatment? Well, so I said, let's evaluate her. We did. That second scan improved, and we saw the same improvement that we saw with trauma, with the divers, with a number of other conditions. I said, wait a minute, maybe we can treat this genetic syndrome. And we did, and this woman improved. And we captured on the imaging, the repeat imaging with video. It was a whole new world. And now I've treated well over 30 different genetic syndromes. And interestingly, they are almost the most responsive of all. We find improvement. And what it goes down to is we now know that hyperbaric oxygen is acting epigenetically and controlling the expression of these genes. And there's overlap in genes in terms of the functions they subserve. So having one gene do just one thing that is, a critical function, and without it, you're a dead person, that doesn't happen. We've got many genes involved with metabolism, with so on. And if you can affect the expression of the other genes, you may be able to accommodate a deficit in one. And that's the conclusion that I've come to try to explain why we've seen. I treated a Down syndrome patient. We had unequivocal improvement on brain imaging and with her functionally, her ability to converse, her cognition, and she was 25 years old when we did this. They have a shortened lifespan. It's pretty clear. It's a genetic syndrome. You can't change that. I didn't think we could have any effect. Anyways, so yes, your concept, is there a category of disease or something where this conceivably couldn't work? I suppose, but I don't know what it is at this point.
Well, we especially want to know autism.
Yes. Well, the second to us, the first autistic child in North America treated with hyperbaric oxygen, we treated here in 1995. And it was the same thing. We were just evaluating every neurological diagnosis as a potential wounding diagnosis. And autism was another potential wound to the brain from a variety of different insults. So what ended up happening, we treated this child and the imaging improved. He improved. He's actually one of the cases in my book. And after that, whole series of autism patients. And now I've treated, I don't know, well over 50 autistic children. And I give parents very solid statistics. And they're identical to one of the published longstanding practitioners who came upon this years after we started treating children. He's a physician, Dr. Dan Rosenthal, who treated his family members for autism. That 80% of the autistic children we treat with this therapy will see improvement in their symptoms and function.
Have you been able to completely reverse dementia and Alzheimer's in patients with HBOT?
Yes. Well, reverse. We don't cure, but we're able to improve their function and even stabilize them in slow decline. And the first demented patient we treated, and this was dementia from diving, was 1989. But very early on, I got referred to another patient who had dementia, and I have to go back and look to see if she was vascular dementia or what it was. But this lady experienced such a significant improvement. Her husband was so pleased, he actually made the donation to our nonprofit that funded the animal study, which is now published on traumatic brain injury. And so now I've treated, I don't know, somewhere in the range of between 100 and 200 people with dementia of a variety of different causes. And the autistic patients, I tell, I quote people, I'm sorry, the Alzheimer's patients, I tell them that 65 to 70% of them that we have treated will see improvement in. The other 30, 35% can't really say that anything happened. And it could be a dosing issue, could be the diagnosis was not accurate. We don't know, but, those who have cognitive decline of other causes, we actually see, like the person who has smoked and drank all their life and maybe has a concussion or so in there and now has premature cognitive decline in their 60s or 70s. Those people actually do even better than the Alzheimer's patients. So again, it's a wounded brain.
Yeah. I think back to Bredesen and Dr. Tenio and how they talk about Alzheimer's type 3 being of a toxin mold exposure. And so I'm thinking, wow, this is really interesting that they've been able to kind of look at this, and they're also working on that. Bredesen has his own protocol and everything. Do you actually have that question within your patient health questionnaire? Like, do you screen for mold exposure?
No, I usually don't. I haven't done that. No. Maybe it's something I need to do.
Interesting.
That
would be interesting to add in and see, because not everyone knows, right?
Actually, if you have a good screening questionnaire or whatever that does this, I mean, I usually find out about it from people who, many people don't know that they've got mold. They only find out after something is brought to their attention. They find it in their house, and then they notify me that they've had a mold exposure, and could that be, consideration in what's wrong with them?
And with all these brain injuries coming from various sources, chemicals, concussion, and now mycotoxins, it all gets thrown into the same bucket, and we have no way to figure out what is what.
It's true. Because the imaging and all the testing you can do is generally non-specific. There's almost nothing that is a sine qua non specific test for registration of any insult in the brain.
How about the new transcriptomic testing? Will that be specific enough to identify patterns that go along with each of these different exposures?
Maybe. I don't know. I mean, I'm going to doubt it, but that's hard to predict.
I know you guys touched on the subject a little bit earlier in regards to HBOT, but why do you think the medical establishment has shied away from utilizing this mode of treatment, since it seems to have such a benefit for a wide variety of disease states?
Well, it's what I talked about earlier, and why I tried to explain why I really wrote that book, The Oxygen Revolution. The message in there is to tell people you can't wait on the medical profession. Just go out and get this therapy for your problem. Then the reason is it's in this very unbelievable but long 360-year history of misunderstanding the science of it. And doctors generally don't want to refer for a therapy unless they understand it, and know the mechanism. Well, that's a medical profession preoccupation. If you look at the FDA, half the drugs they approve for marketing and distribution in the United States, they're the most common phrase in the physician's desk reference, the compendium, commercial compendium of all of the drugs that are available, is no known mechanism of action. Don't know how the drug works, but if you can prove it does work and you get a clinical result, that's all they're concerned with. That's all anybody cares about. It's the medical profession that's preoccupied with mechanism, want to know how it works. And if you don't, they don't want to refer people. The other problem is that specifically with the neurological application, it's been inhibited by the mentality and concept in the field of neurology that the brain is different and is different from all the other organs in the body, and that we don't understand how it works, and we have no treatment for any neurological problems, and that there's nothing you can do for it. You just have to let time take its course after an injury and so on, such that nobody wants to even try until the last 10, 15 years. So for instance, when I showed these, our results at scientific meetings, the answer was, well, those are chronic cases. They would have gotten no better on their own. Well, no, they hadn't gotten better. And so the answer was, you need to do an animal model to prove this. And I was young and naive, and I said, okay, I will do an animal model. Well, before you do an animal experiment, you have to go to an animal committee and you have to put an application before them. And the very first thing you have to do is review the literature and prove to the committee that somebody else hasn't done what you're doing. So you're not just wasting animals. Guess what we found? There was nothing published in the history of science and medicine on treatment of a chronic brain injury in animals. Nothing. And so in our article in 2007, where we published the animal experiment, where we took the human dose and gave it to the brain injured animals, it says this is the first improvement of chronic brain injury in animals in the history of science. It's never been challenged, stands to this day. So from the neurological standpoint, we've had this mentality in our profession, medical profession, that there's nothing you can do for brain injury. And we were taught that in medical school. And I would tell you it's why a significant percentage of the class goes the other way and goes into other specialties. Because most people who go into medicine, you want to do something, you want to actively treat. And neurology was really pretty much a diagnostic specialty. So
I want to point out that three of the most famous epidemiological investigations, the Semmelweis with the hand washing, Dr. John Snow with the cholera epidemic in London, where he removed the pump handle and brought the epidemic to a stop, Barry Marshall with H. pylori. In all those cases, the medical profession refused that evidence because they wanted the answer. They wanted to know the cause before they would investigate it.
yes, exactly. It's like having to have the knowledge before it's even available. I mean, before you can investigate or explain something. Yeah, it's a major problem. So that it's again, one of the things that's inhibited this. And then what happened in the mid 70s, 75, some Czechoslovakian doctors had treated some MS patients and reported improvement in them with hyperbaric oxygen. And my mentor in South Florida, Dr. Richard Neubauer, in 1978 was treating a couple MS patients who had lost sensation in their foot, ended up with wounding, got infected, got bone infection, and was treating them with hyperbaric oxygen for the bone infection, which was a standard reimbursed indication for the hyperbaric oxygen. And lo and behold, their MS neurological deficits improved. And he said, look at this. What's going on here? Well, the obvious was they were treating the wounds in the brain from MS. He reported it, and it caused a firestorm of controversy. And what ended up happening, the Multiple Sclerosis Society went and handpicked their number one researcher, Boguslav Fischer at NYU in New York, funded him to do the study. He did today what is the most rigorous, finest study on hyperbaric oxygen and MS, and it was positive. It showed a benefit. And unfortunately, they kind of turned around and he was discredited. His chamber was taken away. He eventually left NYU. At least the story is told. And there were subsequent studies that were done that were either done poorly or misinterpreted, but eventually the right conclusion got put on it that hyperbaric oxygen had no benefit. Well, that's despite the fact that there are 70 centers in the United Kingdom, that hyperbaric centers that treat nothing but MS patients.
Wow. So what this tells us is that we can't really count on the medical profession to follow through scientifically, that in cases of things that are in doubt, unexplained phenomenon, it's really the patient base that has to come together and support the doctors that are doing this research. Otherwise, it's not going to get done.
Yes, and it's funny you said that, because when you asked, and I was telling you the reason I wrote the book, it's in chapter 14, Roadblocks to the Future. The reason I wrote the book, and what it states in there is, after I go through the evidence showing that hyperbaric oxygen can decrease the mortality by 50 to 60% in acute severe traumatic brain injury, and we're not using it, is that you cannot trust the medical profession at the institutional level to do what's best for your health. You have got to go out and find your therapies, look for the evidence, and take your health into your own hands, and your treatment into your own hands. And that's what the book essentially came to the conclusion about. I was telling people there is enough evidence that this can help you with a variety of conditions that are not approved to get it reimbursed for. You need to just go out and try it.
I think we ought to end it on that point, because
Yeah.
that sums it up right there.
It does. Message hasn't changed now in, what is that? I wrote that in 2006. So.
Well, thank you so
17 years.
much. Thank you so much, Dr. Harch. We're grateful for your presence today, for imparting your wisdom, your knowledge, and your experience of what you're doing with your patients. Thank you so much for being one of the very few honest physicians out there. We do appreciate that. And we are very grateful. Now, if anyone wanted to work with you to receive treatment or wanted to buy your book, Oxygen Revolution, where can they do so?
Oh, the easiest place to buy it is just on Amazon.com. In terms of, treatment and consultations and this type of thing, it's also simple, HBOT.com. Just go to the website, and all the contact information is there, and how we go about doing things and so on. 90% of my patients are from out of state and out of country. So they reach me usually through the internet.
Fantastic. Thank you again, Dr. Harch, and everyone listening. You have a wonderful day.
Same to you. Bye-bye.